We'll just wait for 1 more minute and we'll just start the session. Is it okay with Dr. Gayatri and Terry? Can we wait for 1 more minute?
Yes, absolutely. We'll start at 7:05, maybe 5 minutes.
Thank you. Thanks a lot.
Yes, ma'am.
Very good evening once again to one and all. This is Vinila, Program Coordinator from Hyderabad Center for Palliative Care. So before we start the session, as a normal protocol about the Zoom etiquette, please rename yourself. As I have seen someone by name Galaxy. I think they have changed themselves. Yeah, thank you so much. So please rename yourself as soon as you join. If you cannot rename yourself, please type your name in the chat box and we'll change it for you. This is very important for your attendance, or else like you'll be missing out on it. And during the session, please, if you want to speak, you can unmute, speak, and then requesting all the participants to turn on your video camera throughout the session, because as it is, this is a virtual training and it's very difficult to see participants, and for this, like requesting all the participants to turn on your camera throughout the session. In between, turning off the camera for a minute or two is absolutely fine. And if there is any question, please, if you're not able to speak, you can always type the questions in the chat and type your responses in the chat. We'll always read them out for the faculty on your behalf. And very soon after the session, introduction of the faculty, will be breaking out into 2 rooms. Yeah, so you can also always raise your hand and ask questions. Thank you so much. And over to both the faculty. I welcome both the faculty, both Dr. Gayatri Palat and Mr. Terry. Like, it's really again wonderful to have you both on the same platform. I think initially a couple of weeks ago we had this session with you, and now we are back again here. And thank you so much for agreeing for this time as well, because of this time constraint. I mean, the participants time, the faculty has kindly agreed to change the time as well as per the participants' need. I once again thank both of you and welcome both of you. Over to you.
Thank you, Vinila.
So,
Thank you, ma'am. Thank you, ma'am.
So we'll just break out into rooms. Gayatri ma'am, do you want me to change the slides for you?
I'd like to do it from my end.
Yeah, sure. Yeah. Thank you so much. And we are breaking out into rooms. Just a minute. I think somebody has muted. Can you just please mute yourself?
pharmacological management of pain today in our session.
Sorry, I won't be here for full time.
Sure, like, yeah, absolutely, I can understand. Yeah. So for all of you, remember last time we discussed about how we discussed like chronic pain is so common in our practice, and we are going to see chronic pain, whether you're going to do palliative care or not, doesn't matter. Wherever specialty, whichever specialty, you're going to see chronic persistent pain every day in your practice. And we also understood, there's a better understanding about what changes body takes place in our body when you have chronic persistent pain. So we remember we discussed about sensitization, recruitment, neuronal plasticity, and central sensitization, recruitment, central pain. So, and then how local changes, muscle spasm, vascular reflex changes, all those changes takes place, and somewhere sometimes mutation, and the change becomes irreversible. And so based on this, all of you agreed that earlier the pain is treated, the better we prevent these kind of irreversible changes. Then we also looked at assessment of pain, like how to assess pain. Okay, somebody is in doctors. I'll just give a call to Vinila and just tell that.
Ma'am, I'll assign them to the other room. No problem.
Thank you. Yeah. So, and we also discussed that looking at some broadly like how a good outcome of pain is based on a good proper assessment. And we went on to discuss about asking pain in detail, a detailed assessment. We discussed about PQRST and how it affects your activity of daily living. We also looked at some pain scores which we commonly use to quantify pain. But generally, we believe that pain is what patient says hurt. The patient says, I got pain. As a good pain physician, believe in what patient says. And from there, we go on to assess and understand why the patient is describing this pain. So the assessment part is very important before we decide what pharmacological management we need to take on. So I'll just, please give me one minute. I'll just try to do this sharing of screen. Can you see me here? Hello?
Yes, ma'am.
Yes, ma'am. Yes, ma'am.
Yes.
So you can, any comments you can please, we can put it in the chat. I will respond as and when required. Yeah. So remember this lady we discussed last time about 32-year-old woman with advanced cervical cancer complaining of pain in the low back, radiating to the perineum and the thigh. And we looked at, and this lady described her pain, the back pain, as 7 out of 10. Remember, we did the body mapping, and this radiating pain to the thigh, which was 9 out of 10, burning, constant pain, which is radiating to the thigh. The two kind of pain she described. And we looked at the possible causes of pain, and we came up with this probably is because of cancer per se. Also, cancer eating into the nerves, causing neuropathic pain. One of you mentioned that it could be bone involvement or surrounding infiltration of the surrounding structures like bladder or the rectum, causing visceral kind of pain, and also infection adding to cause of pain. This understanding was very important because based on this, which we decided that we could decide what pain management. Then we looked at the prescription which this lady was getting. This lady was getting tramadol 50 milligram twice daily and injection diclofenac intramuscular SOS. And many of you came up with a lot of reasons that why you challenge this prescription. You all agreed upon how it's so important to have whatever medicine we decide to give, it has to be round the clock. Diclofenac intramuscular is not really recommended in this kind of palliative care patient, which can be very painful. And gastroprotection, do we need to add that to diclofenac? We debated around that, and then we looked at and few other things which came up, based on which we decided on some principles of pain that always give whenever you're talking about chronic persistent pain, we said give the medicine, give the drug by the clock, by mouth, which is the least invasive, because they need to go back home and take medicine all the time. So we have to plan a drug which can be given by the mouth. Each patient is different. We cannot be generalizing that, okay, cervical cancer, this is the pain medicine and this is the dosage. Each patient is different. We have to individualize the treatment. And we also looked at the introduction part of how by that ladder. We looked at how this patient was the prescription was corrected. Diclofenac, patient was getting 50 milligram 3 times a day. The patient was getting tramadol 50 milligram 3 times a day. Patient was also put on bisacodyl, most probably because they thought tramadol can cause constipation. So bisacodyl was also added. In spite of all this, the pain was still inadequate. So we were wondering what next to do. Some of you mentioned increasing the dose of tramadol, and some mentioned, okay, can we add something else? Is it neuropathic pain? Do we need to add something else? That's what debate we were debating around. So this is where we stopped, and we looked at, of course, the ladder. Remember this ladder? We discussed about the 3-step analgesic ladder. The first step being non-opioids, consisting of paracetamol and non-steroidal anti-inflammatory drugs. The second step was weak opioid with non-opioid. Sorry, there's some confusion around people moving around different breakout rooms.
Yeah, I'm just sorry. I'm sorry.
So step 2, weak opioids with or without non-opioids. Whether you want to continue non-opioids, it depends on. Remember, we discussed mostly we use non-opioids when there's an element of inflammation. It inhibits prostaglandin. So prostaglandin it mostly works in inflammatory component of pain. So you have to decide whether a patient needs non-opioids along with weak opioids. And if then the third step, the strong opioid with or without non-opioids. And we also remember we discussed about it's a sliding ladder. We can go up or you can come down. If the patient is and which step of the ladder is determined by severity of pain, not the stage of the disease. If the patient is in early stage of the disease, still waiting for treatment, but patient has got severe pain, we start with step 3. Patient is in last stage, but doesn't have severe pain, it's just mild pain, we can just go by step 1. So it's a severity which decides where to go up, which step of the ladder to choose. And you can always come down. Suppose you start with strong opioids, you do something to take away the pain, the patient's pain comes down, you can always go back to weak opioids or non-opioids. It's an up and down ladder. Along the ladder, we discussed about, of course, addressing the psychosocial and spiritual dimension of pain, because we all realized, remember in pathophysiology, pain is not just physical, social, emotional, spiritual, all the elements, components of pain can add to the pain, and we need to be mindful of that. So this umbrella is there throughout. Whenever you're managing pain, you have to address to psychosocial and spiritual support. And then I added one more thing here in the ladder today. This is what we call adjuvant drugs. Now these medicines will go along the ladder wherever you are. Even if you're in step 1 or step 3, you may have to add adjuvant drugs. Now, what do you mean by adjuvant drugs? Adjuvant drugs are drugs which are primarily not analgesics, but we add where in this situation to add work as an analgesic. Now, for example, when some of you mentioned that this lady must be having neuropathic pain, and you want to add pregabalin or gabapentin. Now, gabapentin is not an analgesic by itself, but here we are using this as an analgesic. So that is known as adjuvant drug, because that is not a primary analgesic which we're thinking, we're adding as adjuvant. Sometimes if you're adding, for example, a patient has got, patient is on diclofenac, patient develops gastritis, and you're adding omeprazole, pantoprazole, and that is an adjuvant drug. Similarly, this patient was on tramadol, and you added laxative like bisacodyl, that is adjuvant drug. So these drugs can go anywhere along the ladder. So this is the ladder. It's very important that you have this very clear in your mind when you're managing chronic persistent pain, because this is a very nice approach to manage pain. It gives you every time it may not work. We can discuss this later. Like sometimes this WHO ladder may not work in all pain conditions, but this is the very core part of managing chronic persistent pain. I just want to hear from you. Are you all right with what we discussed so far?
Yes, ma'am.
You're okay, all of you?
Yes, yes, sure.
Yeah. So
Yes,
this is the standard ladder, and I think many of you, when you're writing, I don't know how it is in Sri Lanka, when you're pursuing your postgraduate training program, or when, if at all you're planning to go abroad, many of these examinations, these steps, these days, they have this as even part of your question. They are often people, when you talk about pay, they talk about WHO analytic ladder. So this is very important to have this understanding. As a next step, I asked you these two questions last time. What are the commonly used pain medicine in Sri Lanka? What are the medicines, analgesics you use? And what are the common opioids which you use in Sri Lanka? I asked you to reflect on this question and come so that we thought we'll discuss this time. So I need to understand these two. So I request, I don't know whether it's possible, Vinila. I thought if we can do some polling based on this. Do you think we can do it?
Just a minute.
Do I have to stop slide?
Yeah, yes, ma'am, you have to. Yeah.
We'll do a quick polling to understand it, because for me it will be very easy to understand each of your perspective about the different analytics which we use.
I think I can only do it from the main session.
Let's try doing this. If it's not working, we'll go back to just having the interaction.
Yeah, yes, ma'am. Because I couldn't see the whole option here because we are into breakout rooms. So I'm not able to see the poll option as it is because we uploaded the questions online, but because we are in the breakout.
Ma'am, give me just some time, like 5-10 minutes. I will upload the questions right away. No problem.
So, okay, we'll come back to this poll.
Yeah, sure. Just
Yeah. Let me know when it's ready.
yeah,
Sure.
definitely.
Sorry about that. Yeah. So once again, we'll go, but because this polling, I thought this will help you instantly let me know what the kind of analytics which we use. So we'll come back to this polling once again, once, they're ready. So can you see this slide? Slide sharing once again?
Yes, ma'am.
Yes, ma'am.
Okay. Yeah. So I thought then, okay, because while you're still waiting to hear from you about Sri Lanka experience, I'll just tell you what is that we have in India. So in India, when you remove, I am not going to detail now because we already discussed paracetamol and non-steroidal anti-inflammatory medications in our last session. And I hope you went and reflected on this COX-1 and COX-2 inhibitors and different medications and the side effect profile of each of those. So we're not going back into that. We just straight away we're jumping to now step 2 of the ladder and step 3 of the ladder. So the common opioids which we have in India are codeine, tramadol, buprenorphine as a weak opioid, and strong opioids, morphine, fentanyl, methadone. I deliberately put pentazocine as like kind of quite lower down and pethidine here, because this is not something which is really preferred for chronic persistent pain. It's not recommended at all. Similarly, pethidine, because of their side effect profile. So that's the reason I put it as a like kind of, even though it is available in India, we don't use it in chronic persistent pain. So we are primarily looking at weak opioids, mostly codeine, tramadol, buprenorphine, and among strong opioid, morphine, fentanyl, methadone. You may or may not have this drugs available, but let's understand, because in palliative care, you may have to require to understand little more into detail about these medicines or tramadol maybe once in more in-depth knowledge, especially when you're working in palliative care. So like I said, in the step 2 of the ladder, weak opioids, We have tramadol, codeine, buprenorphine. Understand a little bit about each of these, little bit. I'm not going into the details. So idea of my class today is just to give an overview, because many of this may not make sense to you because you're not really using these medicines. But when you go back to your practical placement, hopefully after initial couple of months, once we settle on with our COVID and pandemic, maybe you'll have some kind of element of clinical placement nearest to your the palliative care center which is closest to you, and you will be seeing a lot of opioids being prescribed in their practice. So when you go there, you'll connect with whatever we discussed today. So and maybe you're already using some of this. Yeah. So but so the idea is today is just to give an overview. So like I said, step 2, codeine is the one of the drugs which you use in step 2. What we have to understand is that codeine is a prodrug of morphine, which means that when you take codeine and you take it to the body, it is converted to morphine before it gives its analgesic action. So it's considered as prodrug. It's 1/10 the potency of morphine. Suppose if you're using 10 milligram of codeine, when you take into the body, what you get in the end as an end result is 1 milligram of morphine. So 1/10 the potency. And codeine, when you're using, remember the principle by the clock. If you're using codeine, if you want to give it by the clock, codeine has to be given 4 hourly. Now, why I specifically mention this is that many places you have codeine available, and codeine is often in combination with paracetamol. It's not plain codeine which you have. Many pediatricians, they like to use codeine and they give 4 hourly. And it's when you are in combination with paracetamol, when you use 4 hourly paracetamol and codeine, it's too much, which is not really required for those patients. So that's the reason it limits its use. And codeine, what commonly we see in cup syrups. Again, many people, when they're in pain, desperate situation, we give cup syrup. Again, cup syrup doesn't come as a plain codeine. It often comes with some kind of antihistaminics also in combination. So again, it becomes a challenge. In very few places, you have plain codeine. So the argument is that if it is a prodrug of morphine, why to undergo all this? Why don't you straight away give morphine? That is the argument people talk about. And more, many centers, they have done away with using codeine. They are not using codeine anymore. Especially in children, they have banned, I won't say banned, they don't recommend, all international forums, they don't recommend use of codeine in children. The reason being, they say, is that codeine, how it is metabolized in the body, what they found is that some people, they are fast metabolizer, some people are slow metabolizer. So we don't know how codeine will work in the body. So especially in children, it becomes very unreliable how it will act in the body. And that's the reason they say don't use codeine. In fact, when you're talking about the 3-step analgesic ladder in children, they have only 2-step analgesic ladder. Step 1, where they're using NSAIDs and paracetamol, and straight away they're going to step 3. They don't have step 2. That is the standard recommendation in children. Do you have codeine in your center, in your hospitals, or where in your practice?
Yes, ma'am.
Yeah. So I understand that codeine may be available in many of the centers, especially in the remote places. You may not have the privileges of having other opioids. So sometimes you have to use codeine. So you have to understand a little more about codeine. So if from here onwards, when you're thinking about using codeine for your chronic pain, think about using it 4 hourly. Usually it's available as 10 milligram tablet. You have to start with 10 milligram 4 hourly. If pain relief is not better, you have to increase the drug. So we'll discuss how to titrate these kind of medicines, but this is how you use it. The next very commonly used opioid in India, at least, is tramadol. Very common. Every hospital have it. Sometimes they just get it across the pharmacy. But these days, they have kind of, in India at least, they become very strict with its usage. You need special prescription, double prescription, triple prescription for its usage. It comes under controlled medication now. How does it work? The beauty of tramadol is that it is step 2 opioid. When I say opioid medicines, remember all opioid medicines, how do they work? All opioid medicines, they have one common property. They work on opioid receptors. So there are several opioid receptors, mu, delta, kappa, sigma, like that. But primarily it's action on mu receptor, which gives its action. Pain action is by virtue of its action on mu receptors. All opioids, they work on opioid receptors to produce its action. Like I said, NSAIDs, remember we discussed the prostaglandin. It's a prostaglandin inhibitor. Opioids work on the mu receptors. And all opioid receptors. Now we have inherent endogenous opioids, which is released in response to stress, endorphin, like example. But these are external opioids, which we give in response to pain. Remember your pathway? When I made that pathway, nerve endings, dorsal ganglion, dorsal horn cells, thalamus, like that pathway. What you have to remember is that opioids are present in the central nervous system. There are also opioid receptors. They're also available in the peripheral nervous system, even topically. The reason I'm telling you is this because all these opioids, it works topically also. Suppose you have mucositis, oral mucositis. If you apply opioids over the mucosa, it works. So these receptors are there both in peripheral nervous system and in the central nervous system. Now, coming back to tramadol, I said tramadol is opioid, so naturally it works on opioid receptors. So it is a synthetic opioid, works on mu receptor. The beauty of tramadol is that it also has action on inhibition of serotonin and noradrenaline reuptake. Remember we spoke about tricyclic-like action, enhancing the inhibitory pathway, and by enhancing the inhibitory pathway, it produces pain relief. So it has this TCA-like action. So the tramadol has a dual action. It's not just an action as an opioid receptor, as an opioid. It also has like a weak TCA-like action because it increases the inhibitory. These two are the inhibitory neurotransmitters, serotonin and noradrenaline. So it increases its concentration at the nerve ending, and so it works on the inhibitory pathway. So that's the reason they say that tramadol maybe it has this added benefit in neuropathic pain conditions. Especially, you must have seen a lot of diabetic neuropathy, where the people complain of pins and needles in their legs, extremities, and sometimes the sleep is disturbed so much because there's diabetic neuropathic pain. And tramadol may be a good idea to start with because of this action on like TCA-like action. The problem with tramadol is that one problem, because of its metabolite, that it lowers the seizure threshold. So we have to be very careful when you're using tramadol in patients where you expect they may develop seizures. For example, of course, patients with epilepsy, but also in our kind of patients in palliative care, where especially patients with cancer, brain metastasis, it may lower the seizure threshold and it may cause seizures because of metabolite. So that's something we have to be mindful of. Any questions around this? Tramadol? Okay. We move on to another opioid. We call it as buprenorphine. Many places it's known as tidegesic. It has a partial agonist. So it has agonist, antagonist action. Sorry, partial agonist action. That means it's not very strong agonist, but it's a partial agonist and high affinity for mu receptors. But the problem with buprenorphine is that it's a weak opioid again, step 2. The problem is that it has got a ceiling effect. I don't know whether you remember ceiling effect from our pharmacology days. Ceiling effect is, sorry? Yes? Okay. So ceiling effect is that when you increase the dose of any medicine, before it gets its therapeutic effect, it starts showing side effects, which means that it hits the ceiling very fast. So it hits the ceiling means it reaches the level beyond which we cannot increase the dose of medicine. So buprenorphine, even though it's a very excellent, very potent opioid, actually some people, they like to put it as a step 3. Just because it has this ceiling effect, we cannot increase buprenorphine too much. The patient will develop a lot of side effects, and we cannot go up on the dose. That's the reason it is considered as a weak opioid because of its ceiling effect. It can be used in acute and chronic pain, and also many of these de-addiction centers, they use this as a replacement therapy. So many of you are in Sri Lanka, I'm sure they must be using the de-addiction centers or as a drug replacement therapy. It is available as injections and sublingual tablets. Its oral bioavailability is very poor, so we don't have oral preparations. So mostly it is available as sublingual tablets. It is available also as patches. So one patch, if you apply, it works for 7 days. Do you have patches in Sri Lanka? Buprenorphine? Do you have buprenorphine patches, tablets, or injections? Hello? Hello, can you hear me?
Yes, sir. The question is for the doctors. Please, can someone respond, or you can just type yes or no in the chat box.
Do you
Yes, ma'am.
have
We don't have idea.
buprenorphine in Sri Lanka?
No.
Not sure. Okay. So that's the reason I want you, but today when you go back, the medicines with the medications which you're discussing today, opioids, find out whether it's available or not. Because tomorrow when you'll be a little more familiar after this discussion about understanding this medicine. Sorry, the spelling is wrong here. Buprenorphine, B-U-P-R-E-norphine.
We only got fentanyl patches.
Okay, okay, good to know this. Thank you, thank you. That was a very important, relevant input. Strong opioids. Dr. Surin, because you're here, I just want to understand among the opioids which we're discussing, what do you have in Sri Lanka?
We have oral only morphine.
Okay,
Morphine also not widely available.
okay,
That is the main problem. Then we have injections. We have pethidine, morphine, and then methadone. We have.
fentanyl.
Fentanyl. Yes.
ICUs they must be having.
Yeah.
So, do you have methadone in Sri Lanka?
Yes.
Both tablet and injection?
We have injection.
Oh, okay. We don't have injection actually. We only have tablets. That's good to know. And weak opioid, do you have tramadol?
We have.
Tramadol? Weak
No, we have
opioid?
tramadol. Tramadol is widely available. Tramadol is widely available. Even tablet and injection, both are available.
Good. And you have codeine, they said.
Codeine, yeah. Codeine mainly we use codeine with paracetamol. Yeah.
Okay. Codeine paracetamol. Yeah.
Yeah.
That's a standard way to use.
Yeah.
What other weak opioids do you have?
Now we have this NSAIDs. We have all the
Yes,
NSAIDs.
Do you have pentazocine?
Yeah. We have.
Fortwin. Very commonly we call it a fortwin.
Yeah.
So we don't use pentazocine. Okay, now that because you have, let me go back to, sorry, how do I go back? Anyway, so in weak opioids, remember I told you pentazocine, which is actually fortwin. And it is not a very good drug for chronic persistent pain. I'm sure many hospitals, they very easily use pentazocine. Even in India, all peripheral hospitals, they'll have pentazocine very easily available and they use it lavishly. But what you have to understand is that the side effect profile of pentazocine is not good in the real sense. It causes tachycardia, hypertension, dysphoria. So all these reasons, and we don't have any oral preparation. So in chronic pain, nowhere it is used as a mainstay medicine in chronic pain. And so that's the reason I'm not even discussing pentazocine here, because there's no oral preparation. Remember we discussed by the clock, by the mouth. So when you're thinking about a medication which has to be given by mouth, you can't use pentazocine. And it's very dysphoric, hypertension, tachycardia, very short acting. So it may not be a great idea, especially pethidine also similar, no oral preparation. So it's not good for chronic pain. So when you talk about chronic pain with oral preparation, we are left with very few choices. So in among weak opioids, we are left with codeine, paracetamol, what you have there, tramadol, of course. And in strong opioids, you are left with only oral morphine. We'll discuss the fentanyl patches because you have it there. And methadone, again, because you don't have tablets, we are not going to discuss in detail. So we'll focus these two. And again, I'm sure most of you are not using these medicines, I can understand. But have an understanding.
Actually methadone we don't have in Sri Lanka.
Okay, you don't have methadone.
Yes.
So focusing on only these two medicines today. The idea being that when you go back to practice palliative care or when you get attached to one of the centers to see patients how they're doing, so we'll know, okay, this is how it should be used. So this is how we're going to use. Now, I'm a quick polling just to get an understanding. Looks like the polling is ready. So we'll stop here, go back to polling and come back.
Yeah, Shweta, can you just please start the poll, please?
I stop.
Yeah, you can start, ma'am.
But I don't see the poll option here. Sorry, please help me.
Ma'am, since you're the host, there will be a polling option at the bottom of your screen. You can close the participants button and then you can see all the options at the bottom of your screen. There will be some polling option.
Just a second.
My screen is still there?
No, it's done.
I stopped, no?
Yes, yes. Sorry, Shweta, I can't because there's no option here.
Sorry, ma'am, can you repeat?
There's no poll option here
No.
because we are in the breakout room.
Then
because of that?
possibly could be the reason since we
Yeah.
are in the breakout room. So
Yeah.
in the main session, it will happen.
Yeah, because
Okay,
it's
then
not there.
it's okay, Vinila. Then I'll just start once
Sorry,
again.
ma'am. So sorry.
Yeah, sure, sorry about that. So like I said, we have oral morphine, sorry, the spelling is more oral morphine, and transdermal fentanyl and methadone. So let's understand a little bit about oral morphine. I just want to know in the chat, how many of you have seen or heard of oral morphine? If you can just put it in the chat, just to understand whether you heard of morphine given orally. How many of you have done, seen or heard of oral morphine? I see Dr. Kandeepan saying yes. Good to know. Shobika, yes. I'm very impressed actually. I'm seeing yes. Wow. I'm seeing all of you saying yes. Majority at least. Very interesting. So where have you heard this? I see not used, of course. Yeah, that's okay. But you've seen or heard of it. Very interesting. So when I speak to Indian audience, if I'm speaking to a group of doctors in India, often the response I get is a blank. Okay, Dr. Kandeepan is actually using in the ward. I will come back to you, Dr. Kandeepan, but I want to see the response from others. So in Indian audience, when I ask this question, they all give me a blank look because majority of the centers in India, we don't have oral morphine available. There's very few palliative care centers they have it. Even in cancer centers, they don't have it. So I'm very impressed that at least I've seen a lot of yes responses here. And I see some more responses. Dr. Prashant is saying yes. Interesting. Great. Someone is saying only subcut. Wow. Subcutaneously using, that must be injection morphine, right, Dr. Vithuran? So you're using injection morphine. I will come back to you, Dr. Viduran. So tell me something about where do you use, Dr. Kandeepan? Can you tell us more about what you do and where you use? Dr. Kandeepan?
Yes, we are using in the ward, oncological ward, madam.
Wow. And what strength do you have there?
IR morphine 2.5, 5, 7.5, 10 for hourly.
Okay, but what tablets do you have? 10 milligram tablet, 20 milligram? How is the strength there?
5 milligram tablets.
5 milligram tablets.
Yes, IR, slow release.
Okay. Immediate release or sustained release?
Immediate IR.
IR tablets. Great to know.
Yeah, SR also we are having the SR also.
What strength do you have, SR?
SR 10 milli, 20 milli, 30 milli, but it's available is only the 10 milli tablet available. Yeah.
Great, good to know that. So so it looks like in Sri Lanka you have. We are going to discuss in detail at some later session about how to make these medicines available in your respective centers, opioid availability, where Dr. Suren is going to be the main speaker and going to tell us more about procuring opioids in Sri Lanka. But good to know from Dr. Kandipan that you're using it in your cancer center and you have 5 milligram tablets, IR, immediate release, and you also have sustained release tablets available in your center. Good to know that. Great. And Dr. Viduran, would you like to tell us more about your experience of using it as subcutaneous?
Actually, I'm in the mental health unit these days. When I was in surgical internship, I have used that subcutaneous.
So it's injection and you use as in surgical patients for post-op pain relief mostly or surgical pain. Great.
Yeah.
I'm very impressed that you're using it subcutaneous because we're going to have separate session on subcutaneous route of administration because in palliative care we use a lot of subcutaneous medications as a preferred route because remember that that day I told you intramuscular is something we don't like in palliative care because our patients are so emaciated, the muscle bulk is not there. So when you give intramuscular, often it tends to damage the underlying structures and it's very painful. So, and remember, our patients need round the clock. So if you keep giving intramuscular again and again, it gets simply impossible. Patient will not like it. So we prefer subcutaneous as the most preferred route of administration if it is not oral. Of course, after oral, patches and then subcutaneous. So good to know that you're familiar with this concept of subcutaneous. Thank you. That was very interesting. So coming back to oral morphine. So I put some preparations which are available in India. And it all depends on your country, your pharmaceutical company, what is providing you. It's fixed. So in India, we have this immediate release preparation like 10, 20, 30, 60 like that. We don't have morphine solutions available in India. We have only tablets. And we also have sustained release preparations. Again, it all depends on what the pharmaceutical company manufactures. So your country, you may be having a different set of preparations. Do you have solutions, morphine solution?
Yes, we have.
Wonderful. You're privileged to know that you're having solutions because we're struggling, and for some reason, our pharmaceutical company they're not making it. So we have this great challenge of using it in children. So good to know that. So these are the standard preparations. And oral morphine. Remember that this is the gold standard for treatment, especially in cancer pain, for chronic persistent pain in cancer. This is the gold standard the world over. It's not my view. It is not Dr. Suren's view. This is the standard recommended treatment. Wherever you go, in many places, this is the first line. And this is for step 3 of the ladder. Remember, I'm talking about, we are here now at the step 3 of the level. Step 2, we are done with tramadol. We are at step 3 now. And in step 3, oral morphine is the standard. Morphine, I will not go into detail. One thing we have to understand is bioavailability. Bioavailability of morphine is very poor. So when you take oral morphine, only 33% actually reaches, bioavailability. So finally, what is the quantity of drug which reaches the circulation to produce its action? So if you take 10 milligram of morphine, actually only 3 milligram approximately reaches the circulation to produce its action. It undergo extensive first pass metabolism in the liver itself when you take oral morphine. I'm not talking about injection here. Whatever we are discussing now onwards, it's all about oral morphine because that is the formulation which we use in chronic persistent pain. So oral morphine bioavailability is very poor. This has a relevance, especially when we'll come later why we're discussing this. I mean, mostly it is metabolized in the liver. Glucuronidation by it happens, and you have 2 metabolite, morphine 6 glucuronide, morphine 3 glucuronide. Now, we have to understand that this is the active metabolite in the liver. So, which means that this metabolite also gives pain relief. This is not so much relevant here, but this is the metabolite which gives pain relief. Now, this is a metabolite which is responsible for some undesirable problems which we see with opioid or morphine usage, like neuroexcitability. We'll come to that, but this is the metabolite which we see. But we have to understand this both these metabolites. Now, this relevance is that when you have a patient with cancer and liver problem, cancer with liver metastasis, I will not be so worried about using morphine in patients with liver metastasis, because what will happen? It will not get metabolized. That's all. So it's not so much of a concern for me. I will be concerned if you have a patient with cancer and using morphine, a patient having renal failure, because the major excretion of these metabolites happen through the kidney. And if the kidney failure happens, these things get accumulated. This accumulation of these things, and it can cause, with this, you'll have prolonged action, and with this, we'll get a lot of problems like delirium, neuroexcitability. So in general, remember the take home from here will be, when you're using oral morphine, it will not be so much of a problem when they have liver metastasis. You can use it when there's a liver damage. But when there's a kidney damage, for any reason, you have to be very guarded when you're using morphine. It applies even to injection morphine, but specifically for oral morphine. So, those who are using oral morphine, they know it already. You must have heard what they're saying about it. But generally, when you're talking about, remember, by the clock, by the mouth. So by the clock, oral morphine, immediate release, when you talk about immediate release, its duration of action is only 4 hours. So suppose you're using oral morphine, you have to use 4-hourly dosage. There is no like BD dosage. Why it's so not, it doesn't have so much pain. So let me use BD. It will not help. Whatever the dose you decide, whether it's 2.5, 5, 10, 7.5, whatever dosage, it has to be given 4 hours. And we say double the dose at bedtime. I'll come to that. Why double the dose at bedtime? No. When you say 4-hourly, typically when we tell the patient, start your dose at 6 a.m. As soon as you wake up, take the first dose. It's all right, even if you're not taking food, start your first dose. So if you start the cycle from 6 a.m., the next dose, 4 hour means 10 a.m. And then next dose will be 2 p.m., 6 p.m., 10 p.m. When will be the next dose after 10 p.m.? If you say 4 hours?
2 a.m.
2 a.m. Now, if you say 2 a.m. dose, most patients, our patients who need palliative care, even otherwise, their sleep is so disturbed. And if you tell them you have to take your next dose at 2 a.m. every day, the patient's sleep is disturbed, the family's sleep is disturbed. And once you get up and you wake, you may not go to sleep fearing that they may miss the 2 a.m. dose, and they will not get sleep. And when they stay awake after 2 a.m. or sometimes they don't get good sleep. So you're disturbing the whole rhythm of the sleep. We want our patients to sleep well. So what they say is that it is all right to give double the dose at bedtime so that they don't have to wake up at 2 a.m. to take the next dose. This is something very important to understand. Now here you may challenge, if you're giving the double the dose at bedtime and the next dose is only at 6 a.m., which means there's a good gap, almost 8 hours gap. Why don't you have the same 8-hour gap in the morning? You may ask this question. Possible? Yeah. So what may happen when you give double the dose at bedtime? They say it is enough to cover the whole night, but there may be element of drowsiness, but which is all right because anyway they are sleeping. But the same, if you suppose you give double the dose in the morning at 6 a.m. or 10 a.m., the patient feels sleepy, that is not acceptable, because I want my patient to be as active as possible in the waking hours. So if you give double the dose, thinking that let's give it 8-hourly, he will be sleepy, which is not acceptable. So that's the reason the standard the dosage pattern is 4-hourly dosage and double the dose at bedtime. Now, this is something you have to be very clear. When you go back to your palliative care clinic, you will see most of your prescription in this pattern. There's another thing which we call it as rescue dose for breakthrough pain. Many of these cancer pain patients, a typical prototype for chronic pain is cancer pain. What happens in chronic cancer pain? Often they get pain in between sometimes for some reason, which is known, we call it as breakthrough pain, breaking through the baseline pain. Otherwise, they're fine. Suddenly, they get some colicky pain or some pain in the throat or some ear pain. Suddenly, it comes in between. We give medicine for that breakthrough pain. It's known as rescue dose. Essentially, it is SOS dosage, which you give in addition to this regime. This is known as rescue dose. So we give rescue dose in addition to this round-the-clock medicine. Now, this option should always be given to the patient, because if they don't give this option, suppose they get in between pain, they suffer unnecessarily. So, a typical prescription of your oral morphine, this is how it's going to look like. If Dr. Suryan is writing the oral morphine to a patient, if he needs 10 milligram tablet, they will write 10 milligram morphine, Q4H, that means 4 hourly, 20 milligram bedtime, that means double the dose at bedtime. And they say same dose as the round the clock dose as the rescue dose. That means 10 milligram 4 hourly, 20 milligram bedtime, and they say 50 to 100%, like 5 to 10 milligram SOS dosage. So we teach the family. Suppose you take one medicine at 10 a.m., the next dose is at 2 p.m. At 12 noon, if you get pain suddenly, more pain, please take extra dose of 10 milligram. It's all right. But don't skip the next dose. Don't skip the 2 o'clock dose. This is how we teach them. And keep a record of how many rescue doses you need in a day. This is how you teach them. So if the patient comes back, patient is on this treatment, this prescription. Dr. Suryan has given this prescription. The patient comes back after 48 hours and he says, yes, doctor, I took like this, but my pain was coming back in between and I took almost 4 extra doses, 4 rescue doses. What does it mean to you?
The initial strength was not enough.
It was not enough. So what will you do?
Increase the dose.
Sorry?
Increase the dose of
Absolutely. So if there are more than 3 rescue doses, then that means that you need to increase the baseline dose. And how much to increase? They say 50% of the original dose. Remember that when you are increasing the dose of medicine, when there are too many rescue doses or pain relief is not enough, we increase by 50.
வலிப்பு வர chance இருக்கு. So because they are prone to develop seizures in children, we will not give tramadol. So both tramadol and codeine is not good for children. So குழந்தைங்களுக்கு நம்ம டைரக்டா ஸ்டெப் 1ல இருந்து நேரா ஸ்டெப் 3க்கு போவோம். புரியுதுங்களா? ஸோ இம்பார்ட்டன்ட் நீங்க மனசுல வைக்க வேண்டியது ஸ்டெப் 2ம் ஸ்டெப் 1ம் சேர்த்து கொடுக்கலாம். There are 2 commonly used drugs, tramadol and codeine. இதில் நம்ம ஏதாவது ஒன்று தான் கொடுக்கணும். புரியுதுங்களா? Any questions? ஏதாவது டவுட் இருக்குதுங்களா?
No.
Third, this step WHO analysis patternல மூணாவது step 3, அதாவது strong opioids. We give what is called strong opioids. Strong opioids where we will give severe pain. சில பேஷண்ட்ஸ்க்கு step 2 drugs வச்சுட்டு வேதனை குறையல. They don't have good pain relief with step 2 drugs also. Step 1 கொடுத்துட்டோம், step 2 கொடுத்துட்டோம், வேதனை குறையல. அப்ப அவங்களுக்கு நம்ம step 3 கொடுக்கணும். Okay, to get adequate pain relief. Commonly used step 3 drug என்ன? Morphine. Okay, நீங்க மனசுல வச்சுக்கங்க, keep it in mind. When you start step 3, you should discontinue step 2. Step 2 drugs நீங்க கொடுக்க கூடாது. Step 3 கொடுக்கும்போது step 2 drugs கொடுக்க கூடாது. காரணம் என்ன? Just 1 minute.
That is also opioid.
Oh, yes. Yes, very good. Okay. See, in step 3, what we are giving is strong opioid. நம்ம ஒரு strong opioid கொடுக்கும்போது weak opioid கொடுக்க அவசியம் இல்லை. There is no use in giving weak opioid when you are giving strong opioid. புரியுதுங்களா? அப்ப நம்ம step 2ல இருந்து step 3
sustained it means it's slow release. So when patient is on sustained release, you just have to take twice a day. If it's 24-hour preparation, just once a day. It all depends on what you have. It's not so good for unstable or uncontrolled pain because it works slowly. Suppose somebody is in severe pain, if I give sustained release, it will not work immediately. So it's not really recommended for those. Remember, for breakthrough pain, suppose patient's pain comes back in between, suddenly severe pain. If you give sustained release, it will not work immediately. So for breakthrough pain, again, you have to use immediate release tablet. So it's not a good drug for breakthrough pain again. Suppose the patient is on nasogastric tube feeding, or the patient is having feeding jejunostomy. You cannot crush that sustained release tablet because it has the manufacture is such that inside it has got capsule and a lot of granules. If you crush it, it loses its property. So you cannot crush sustained release. So again, you have to go back to immediate release preparation. So these are the limitations. Otherwise, it's a nice way to prescribe because many patients, they just don't like 4-hourly medicines. So they'll say, how many times doctor I have to take? I have so many other medicines to take. So how do I do this? So give me something simpler. So especially when the patient don't understand and they don't like to take, this is better, but it has its limitations. Any questions or comments so far?
In case of initial management, we start with the immediate release and then switch to the sustained release. So then right away you start the sustained release depending on the pain.
Absolutely, that's a very good suggestion. As a standard protocol, always start with immediate release. Understand patient's opioid requirement, how much he needs. Once he's stable on certain dose, then you convert to sustained release. Now, conversion also you have to understand, like how will you convert? Suppose patient is on 10 milligram 4-hourly. 10 milligram immediate release 4-hourly. So in 24 hours, he'll require 6 doses. So 4-hourly, when you say there are 6 doses. So 10 into 6, 60 milligram. So he needs 60 milligram in 24 hours. Suppose I need to convert into 12 hours sustained release. I have this preparation, 12 hours sustained release. What will be the sustained release dosage?
12 or 30 milligram.
30 BD. Simple.
BD, yes.
So you divide into twice 2 doses. So we calculate the 24-hour dosage and divide into 2 divided doses. That's how you convert to immediate to sustained release. But as you suggested, good idea, first stabilize on immediate release, know the patient's dose requirement, then convert to sustained release. Do you want to take a break, 5 minutes, come back? Are you okay? Okay, we'll continue.
Yes, ma'am.
Yes, we can continue. No? Prashant.
Thank you. Dr. Suran mentioned that all of you have transdermal patches available in Sri Lanka. Now, same in India. You may not have oral morphine available, but you will get transdermal patches in most of the hospitals. You know why? Now, transdermal patch, oral morphine, if you look at the costing part of it, oral morphine is very cheap. It just costs in Indian rupees less than 1 rupee, 1 tablet. Whereas transdermal patch is a very expensive drug. The equivalent dose, if you look at Indian rupees, for a day, if you using oral morphine, it will cost you 20 rupees. The same equivalent, if you convert into transdermal fentanyl patch, it will cost you easily around 350 to 500 milligram rupees, Indian rupees. So much of difference. Now, because the fact that today we have transdermal patches everywhere is because of.
I didn't get that.
Sorry.
Recording.
So the reason we are getting transdermal patches everywhere today is very much because it's a pharmaceutically driven practice. Most of us as a doctors, once we pass out, a lot of our training happens by how these medical representatives teach us, isn't it? So we learn, all the new drugs, we learn from them. They'll come and tell you, this is the wonder drug and this works the best. And the studies have shown that this works. And we are under this pressure to use it also sometimes. I don't know how it is in Sri Lanka, at least in India, it is like that. And so a lot of our learning happens here with in our how the medical representatives teach you, and it's freely available. That's the reason, because it's expensive. The company has an interest to sell it. That's the reason it is available. But remember that this is never a first line for any chronic persistent pain. Nowhere in the world it is used as first line management. It has its lot of limitation. First of all, let's understand how it works. The transdermal patches, how it works, when you apply the patch on the skin, the drug, it has a matrix, the drug gets absorbed from there, and under the skin, it creates a deposit, we call it a depot, in the subcutaneous tissue. So there's a small depot created in the subcutaneous tissue, and from there, the drug is absorbed into systemic circulation. That's how it works. It doesn't go directly into the circulation. It gets, when you stick a patch, from the patch, the drug goes into the subcutaneous tissue, and from there, it goes into circulation. Now, what happens when you have this kind of arrangement? Like I said, and beauty of it has its advantages also. Once you apply a patch, you need, for 3 days, you get pain relief. Only after third day, you have to remove the patch. So many patients, they love it because you don't have to take 4-hourly morphine, double the dose at bedtime, rescue dose, all this confusion is not there. You apply a patch, 3 days, you're ready. But most of the time in practice, it doesn't happen like that. What are the problems which we face? Suppose you have a patch and you get that breakthrough pain. Remember I told you in between sometimes they get increased pain. There's no way I can release more medicine through the patch. Again, I have to take immediate release morphine tablet. So whenever you prescribe patches, again you have to say that in addition to patch, you apply this patch, but you also take oral morphine in between for your breakthrough pain. But because that adds some confusion, so it's not a very nice thing to do. Now, latency of action. Remember, I told you it works as a depot. It works in the subcutaneous depot. So it doesn't act immediately. Someone is coming in severe pain. If you put a pad, only after 12 hours, it will have some action. Can you hear me, Vanilla?
Ma'am, I think there's little lag, like when you started and then again started back.
Is it better?
Yeah, now it's better.
Okay. So what I'm saying is that when someone is coming in severe pain, you apply the patch, it doesn't work immediately. It will work after 12 hours or 18 hours. It stabilizes by 24 hours. So there's an onset of action is delayed. Similarly, if you see a patient who's on patch and the patient is drowsy, and I feel, oh no, he's got too much of a dose, and I remove the patch, he will not come out of its action because the depot is there in the subcutaneous tissue. It has to get depleted. The subcutaneous depot has to slowly get depleted. Then only he will be out of it. So again, it takes almost 24 hours for the depot to get depleted. So it does not help work in breakthrough pain, or the slow onset of action, and slow because of slow release, removal after removal also, the patient does not come out of it. Now in summer weather, all these patches does not stick properly. So you'll have this, when you apply sweaty areas, you apply the patch, it sweats, the patch may come off a little bit here and there. So absorption is very erratic. Many a times what happens when there's a summer, you have increased vascularity. Sometimes it may get more absorbed. So we don't know how it works in summers and it doesn't stick properly. So all these problems are there with fentanyl patch. So I would say it's a good drug to use. One, you must use it for stable pain, like one of you mentioned, just like sustained release preparation. Start on oral morphine, immediate release, stabilize him on certain dosage. Once you know the dosage, then you convert to fentanyl patch. There's a nice table. I'm not going into detail of it. You'll get it anywhere. Just Google, you'll find morphine fentanyl conversion. There's a ratios there. You just refer to that table and you'll know. Suppose 10 milligram morphine means 25 microgram of fentanyl. More than 20 milligram of morphine, 50 microgram of fentanyl. The conversion table is there. You can just refer to that table and convert. So you must stabilize first on oral morphine, then convert to fentanyl because unstable pain, it's not a good drug to use. Fentanyl patch is very good when the patient cannot swallow orally, when they cannot take medicines orally. This is the next best bet you have because I don't want the patient to go back home on injections. So patch will be a better idea. So all these oral cancer patients, when they have swallowing difficulty, maybe think about this. Again, fentanyl patch is a good idea when the patient has renal failure because it's very safe in renal conditions. Remember morphine, I said it has active metabolite, it accumulates. Fentanyl doesn't have active metabolite, so it's very safe in renal failure. But most important for our patients, it's very expensive. So if you ask the patients to buy it, then they may buy for few patches. After that, they'll say, no, I can't afford, and they stop taking, and then they suffer. So I just want to understand, in Sri Lanka, do you give these medicines or everything from the government, or you ask the patients to buy from outside?
No, usually Sri Lanka, the good thing is at the point of delivery, it's most of the things are free, not like in India. So then, if it is available in the state sector, and then everything is free, so we don't ask. But if it is not available, then we want to give. Then only then we will prescribe and ask them to go and buy it outside.
Very good to know that. Great that your state is giving you. But even for the state, we should be very rational with our prescription. Like if you have, because we say we are not a very developed country, we have resource poor setting. So we should be responsible for our prescription. So indiscriminate prescription where it is not needed, wasting, and we talk what we call pharmacoeconomics. So we have to be mindful of that. So you have to be very careful when you're using these kind of medicines. When you have an alternative, such a cheap oral morphine is available, think that. And again, always I feel that first line.
That is a problem, and actually we will discuss in that thing. But the morphine is a very cheapest drug. But then in Sri Lanka, we don't produce morphine, and we purchase, go and buy outside. And sometimes that we purchase that may be costing around 25-30 rupees for Indian thing.
So it's not really cheap for you, morphine.
Yeah, but that is some of the forums, they really highlight that
Okay.
issue, the way that, because you produce now, then in India, then that's very cheap. And how much that cost?
Sorry?
In India, you produce now, that how much that cost?
So for example, in MNJ, we get it in bulk. Vinila is the main person who helps me to get all those medicines, opioid medications. Vinila, how much does it cost? 10 milligram tablet?
It's less than.
Sorry, we can't hear you.
It's less than 1 rupee, sir. Sometimes it's 90 paise and sometimes it's 1 rupee. One
Yeah.
10 milligram tablet.
Yeah, that is a cost, and sometimes lesser than the paracetamol. So that is the price of real morphine. Yeah.
And how about fentanyl? How much does it cost?
I don't have any idea about the fentanyl in Sri Lanka. I need to check that.
Yeah, maybe next time all of you please go and do this homework. You try to understand all these things so that when we come back next time with opioid availability class with Dr. Suryan again, we'll all be a little bit more prepared with all these questions which we are asking each other. Yeah, because as a people, like we always talk, especially in palliative care, we talk about pharmacoeconomics because as it is, our patients are so burdened with all these costs of cancer treatment and all these chronic diseases. They spend a lot of money on disease-oriented treatment. And by the time they come to palliative care, they're already ruined, financially totally ruin. And when we add indiscriminate prescription without taking into consideration their economics, we add more burden to their suffering. So we call it as financial pain. So we should be very even generally, not just in palliative care. I feel that in medicine we should be mindful of patients' financial suffering, and we should not add financial catastrophe to the patient and the family. So all the more in palliative care, we were very careful about when we write prescriptions, we write only what is needed. And also when you write too many medicines, we talk about drug interactions and what implication it can have in the body because of that. So we have to we discuss, we give a lot of consideration to the pharmacoeconomics part of it in palliative care. I'm not going to discuss detail about methadone. In India, we got methadone only in like in last 4-5 years. It's a wonder drug, again, we feel, because it has a lot of other actions. Other than, remember I said methadone is opioid, it has its action on opioids, but it also has this NMDA receptor antagonist action. Remember when I told you about neuronal plasticity and central sensitization, how the central nervous system gets very excited. So it helps to calm down the central nervous system. Methadone is one of those drugs which we can use. So very good for many of this high central sensitized central pain. So methadone is a very useful drug. But in India, again, we are not using this as first line in most places, but very complex neuropathic pain conditions. When they have a lot of these complex pain conditions, we switch over to methadone. Like I said, we use this opioid rotation. I mean, again, we have it as tablets and syrups in India. Use it, but there's a lot of cautions. We have to be really trained to use methadone because it has a lot of drug interactions and sudden deaths are reported with methadone. So we have to be very careful. But only the important thing you have to understand is that it has its action, which is it's a beautiful drug if you know how to use it and if it is available. Again, methadone is very cheap. It's like almost like morphine or cheaper than morphine, I would say. It's very cheap medicine. And so I think as a palliative care activist or a palliative group, all of you, you should work with your government to get methadone also in your list of essential medicines, because it is going to be very useful for you in your practice. Something to think about. Yeah. Now, this is a patient. Remember that lady with this cervical cancer, back pain radiating to the thigh. This lady was finally put on morphine, 10 milligram Q4H and 20 milligram bedtime. Patient was also prescribed bisacodyl, probably morphine constipation they thought about. Patient was on diclofenac and omeprazole. Now, their family is saying she's showing some abnormal behavior and talking irrelevantly. Cervical cancer patient showing abnormal behavior, talking irrelevantly. What do you think is happening based on this prescription? There could be other reasons, metabolic reasons like chronic renal failure, because often in cervical cancer patients, we see renal failure is a very common complication. Or I don't know whether she was diabetic, hypoglycemia, whatever, but she's showing signs of abnormal, talking irrelevantly, abnormal behavior. Probably she is having delirium. So based on this, do you see any problem here? Okay, because many of you are not used to, you may not think about it, but we have to understand some things about when you're using opioids. Let's have a little more detailed understanding about its other problems which we see. We have to understand the difference between the side effects which you see with opioids versus toxic effects. Side effect is something which we see even with therapeutic dosage. When you're even with suppose you're using opioids and you develop constipation in its therapeutic range, that is known as side effect. Toxic effect is when the opioid dosage is started, when with this opioid dosage patient is doing toxic symptoms. That means we can't go up on the dose, we have to come down on the dose. Patient is reaching the toxic level. There are some problems which we see with use of opioids which are side effects. That means we see with therapeutic dosage, and we don't stop morphine or we don't reduce morphine just because patient has developed side effects. The common side effects which we see with the use of opioids are constipation, nausea, vomiting, urinary hesitancy, tiredness, and itching. I will focus on these two. Remember that more than 95% of patients, when they are on opioids, they will develop constipation. Now here, if you notice, I'm saying opioids, I'm not saying morphine. All opioids, whether you're using fentanyl, tramadol, codeine, or morphine, almost all your patients will develop constipation. And 1 in 3 patient will develop nausea and vomiting. So you have to be aware of these two problems. They say the hand which writes opioid should write laxatives. So, and also the drug of choice, the drug of choice for laxative is stimulant laxatives, not softeners or not bulk laxative. It has to be stimulant laxative because it reduces the peristalsis, and that's the reason you develop constipation. So the hand which writes opioid must remember that patient may develop constipation. Patient will develop constipation. You must add laxative, stimulant laxatives like bisacodyl. Do you have bisacodyl in Sri Lanka?
Yes, we have.
And nausea and vomiting. And the drug of choice for opioid-induced nausea and vomiting is dopamine receptor antagonist. So we have metoclopramide and haloperidol. Haloperidol in a very small dosage, like we start as small as 1 to 1.5 milligram bedtime. Otherwise, metoclopramide. So these are the two drugs which we use for opioid-induced nausea and vomiting. Please remember these two. Yes, you can also face all these problems because of its anticholinergic action. Urinary retention, tiredness, itching, dryness of mouth also, which we may see. So like I said, they always prescribe a laxative prophylatically with all patients who are on opioids, and always give antiemetic. Tell them. Patient may say, I don't have constipation, doctor. Then you have to explain to them. The patient education is very important when you're using opioids. They need to understand a lot of things when you're using opioids, which they need for all medications which you use, but specifically for opioids. And of course, antiemetic. And you tell them, I don't have vomiting, doctor, they'll say. I'll say, yes, you don't have vomiting, but sometimes when you take these medicines, you may develop some amount of nausea, vomiting. Please keep this with you, and you take it as when if you have this problem. So this is how you explain to the patient. Now, what you have to look for is toxic effect, because if the patient develops toxic effect, you have to reduce the dose of opioids. That means it's above the therapeutic level. Undue drowsiness. What are the toxic effects which you see? Undue drowsiness. Typically, a patient will say, Doctor, I don't know why, but sorry, I'm trying to say in Hindi. So I just nod off even while talking. I'm eating food, I'm feeling sleepy. I can't eat food. I can't concentrate. I'm feeling so sleepy. That is known as undue drowsiness. Myoclonus. Typically, a relative will explain, I don't know why, doctor, when he's sleeping, he is having some jerky movements. Sometimes patient may also tell you that I don't suddenly my hand goes like that, some kind of jerky movement. That if you see this sign, you think, is the patient developing toxic effect? Do I need to reduce the dose of opioids? Delirium. Patient, family will tell you the whole night he did not sleep. He was as if talking to someone. He was just pulling his clothes and showing abnormal movement and talking to himself. Then you suspect delirium. Definitely, that's the toxic effect. And you have to think about reducing opioids. So these are the, usually they go in sequence like this. At this stage, if you catch, you avoid these two problems. So when the patient is too much showing drowsiness, I'll be suspicious. I'll be suspicious if the patient starts saying, I don't know why, doctor, I'm getting a lot of dryness of mouth. So one question I'll ask, do you get bad dreams? No, doctor, I don't know. When I close my eyes, try to sleep, I get bad dreams.
Any other questions? Okay, then shall I continue?
Yeah.
Yes, sir. Next is bone pain. Now, bone pain is a separate pain in itself. It is a part of nociceptive pain. Bone pain is சொல்றது ஒரு nociceptive pain ஓட part தான். But the pain experience and all is very different. അപ്പം bone pain க்கு ஒரு special management തന്നെ வேண்டி வரும். அது ஒரு ஃப்ராக்சரோ இப்போ ஒரு பேஷண்ட்டுக்கு போன் மெட்டாஸ்டைசிஸ் இருக்கு, அது கொண்டு அவங்களுக்கு ஒரு போன் பெயின் இருக்கு. ஒரு போன் மெட்டாஸ்டைசிஸ் இருக்கு, அங்க ஒரு லம்ப் இருக்கு. ஸோ தே வில் ஹேவ் சம்திங் கால் போன் பெயின். ஓகே, நம்ம போன் பெயின் WHO அனாலிசிஸ் லேட்டர்ல வச்சு தான் யூஸ் பண்ணி மேனேஜ் பண்ணுவோம்.
You see respiratory. Otherwise, normally we don't see respiratory depression in palliative care practice. So that fear is quite unfounded that morphine causes respiratory depression. It never happens. We see around, I see around 70 patients every day in our OP. And all of them, they are on oral morphine. They all come, they take morphine, they go back home, they're driving, they're going on to do their work. We don't see patient having respiratory depression. So please, this fear is quite unfounded when you are using oral morphine in a dosage which is appropriate for his pain. Some of the opiophobia which we see with morphine, the fear of morphine. Withhold morphine for the last days of life. Why are you giving him morphine now? He's not dying. You give morphine only. Am I going to die, doctor? You're giving me morphine. I don't want to take it now. This is the fear patients have. Often they fear that morphine is for the last days, which is not true. A lot of our patients, while they're undergoing radiation or chemotherapy, they develop severe mucositis in the mouth. They can't even swallow. It can be so painful. Vinila sees this every day in her OP. She sees so many patients with a lot of mucositis. We put them on morphine. They finish the radiation. The mucositis resolves, and we stop morphine. It's not that only in the last stage we give. So it's not true that it's only for the last days. Morphine hastens death. Are you going to kill me? Morphine causes death. Again, this is not at all true. On the reverse, what we have seen, many of these patients who come to our palliative care clinic, they come in a very bad shape. When we put them on morphine, they get good pain relief. They get up, they start eating better, they start sleeping better, and they feel better. Overall, the mood improves. They live longer. We have seen many patients, they say, now doctor, I'm feeling so much better. I want to go home and spend time with my family. Many of these patients, they get discharged, they go home. It's not true that it hastens death. Another fear, morphine causes addiction. Now, this is another big reason that most of even that if you're writing morphine tomorrow, your consultant may say, hey, why are you writing morphine? You unnecessarily cause addiction. Again, this is not true. I want to quote this study, which was done in India long time back in Calicut, where they looked at 1,500 patients who are on oral morphine. And what they found is addiction is not likely so long as oral morphine is used in opioid responsive pain in doses adequate for pain relief. First of all, you have to use morphine in opioid responsive pain in a titrating dosage for pain relief. Oral morphine, when it's proper dosage, it does not cause addiction. This is a universal. There are many studies we can quote to say that it does not cause addiction. See, addiction means when the people take this for recreational purposes. When you inject drug, it goes to circulation, and you get that immediate kick, and you feel good about it. You get euphoria, and you feel good about it, and you enjoy that experience. When you take oral morphine, what happens? First of all, you have to swallow the tablet, and it goes into your system. And by the time it produces the action, it takes some time, half an hour. And then it's only 1/3 which reaches the circulation. So you don't get that kick. So you don't feel like taking oral morphine. Moreover, if you take more dosage, if you don't have so much pain, you'll be confused. And nobody in a good state of mind would like to do that. Yeah. So it's not at all a thing which causes addiction. So all this fear is quite unfounded here Morphine causes addiction. Morphine causes respiratory depression. Provided you know how to use it, how to titrate the dosage, and you have to use it for pain. Um, any questions so far?
So how to titrate? What is the frequency of titration of the oral morphine?
Good
So
question. How frequently do you titrate? Normally, it takes, they say, to reach a steady blood level, steady state, it's say 48 hours. If the patient has a severe pain, maybe I'll do it daily basis, but then I'll be carefully watching him. I'll admit and watch him. If the patient is going home, preferably after 40, suppose he's of opioid 9, he's never taken opioid before, I'm starting him on opioids, and I'm not very sure about its dosage. So I'll say after 48 hours, can you give me a call, or we arrange for a call, or some kind of follow-up we should do to understand. Otherwise, admit the patient. Otherwise, when they go home, we'll say, call us. I'll never start a patient on opioids and send them away for 2-3 weeks, just like that. I'll initial titration, I'll closely monitor and reach the stage which is giving him pain relief. So almost every 48 hours, I'll increase the dose, 50%, 50% like that. And but point is that we'll have a backup of SOS dosage. We'll not allow him to suffer during that 48 hours. We say, please take rescue doses. I might keep a note of how many rescue doses in a day you need it. Take liberally. Don't feel hesitant to take rescue doses. Yeah, sorry, you're saying something?
The better option is start with the in-ward admission and initially titrate and then discharge the patient with a stable dose. Oh, you are prescribing the direct away and monitor in 48 hours time and
yeah,
get the
that is
feedback
good.
and
Tomorrow, but if you have more patient load, you can't be admitting all the patients in IP, right? So it may not be practical sometimes. So that's the time we say, okay, even if you are giving for 1 week, we say liberal rescue doses and come back and tell us how many, what is the average rescue dose you need. That will give you idea. So you're also protecting the patient so that they don't suffer during that period. But start small, go slow, and you're safe, especially in outpatient basis when you're using it. Like this, we already discussed. Now, same lady, her morphine dosage right now, she's on 20 milligram 4 hourly, 40 milligram bedtime, and 20 milligram SOS dosage for her breakthrough pain. And she's on bisacodyl, she's on diclofenac and omeprazole. No pain relief, but she's drowsy. She still says, I got pain. I've still got pain radiating to my thighs. It's still 3 out of 10. What to do, but I'm feeling very sleepy now. Will you go up on morphine at this stage?
No.
No. Patient is drowsy. If I increase now, patient may go to the toxic level. So I cannot go up on morphine. So what do I do now?
Maybe we can increase the dose of diclofenac at
Diclofenac already, okay, maybe we'll make it 3 times a day. But still, it's quite a severe pain. And yeah, one option, look at other medicines, diclofenac increasing. But I'm expecting this kind of cancer pain, this increasing one more dose of diclofenac may not still give the benefit.
At adjuvants.
Yeah.
Go
Think
for
about
the
it.
thing.
Again, at this stage, what I'll do, okay, now she's getting drowsy, no pain relief. Let me take a step back and understand what is happening. Once again, reassess. What is the pain which you are experiencing now? I still have that back pain is better now, but that radiating pain is still not better. Okay, that looks like neuropathic pain. And remember that neuropathic pain often they are not fully opioid sensitive. So in such kind of neuropathic pain condition, if you increase further the opioid, patient will be sleepy, still patient will not get pain relief. Then you have to think about what is the medicine which you can add specifically for neuropathic pain. And we call it as adjuvant medications. Like you said very correctly, here we'll think about adjuvant medications. And remember that all pain cannot be treated with morphine. Somebody's got muscle spasm, you have to use muscle relaxant. Somebody got neuropathic pain, you have to use neuropathic pain medicine. Like that, you have to think about the cause of pain and treat pain. Not all pain we can just morphine is the panacea for all that. This is what we call, then we have to think, what is the cause of pain? Like I said, reassess. Is it neuropathic pain? Is it bone pain? Often the bone pain also does not respond to opioid fully, partial response. Muscle spasm. Suppose, look at this lady's posture. All the time she's sleeping like this. Don't you think her back muscles will take a toll by sleeping like that? So it could be simple muscular pain in the back, which is causing. So I have to think about, is it muscle spasm or muscle relaxant? Like you mentioned in the first session, is it other issues which is causing her pain? The pain is not coming down. What about her psychosocial and spiritual needs? How about this? What percentage of patients in your practice take medicine as per your prescription? Take a guess. You write a lot of fancy medicines, hoping that patient to, with the hope that you're trying to help the patient. But what percent of patient actually, sorry, take medicines as per your prescription? Take a guess. In your regular practice,
50%.
50%. Someone is saying. Any more guess? Someone is saying 70%. Yes, true. It's like kind of internationally, it's not my country or your country. Universal, it's a universal fact that more than 70% of patients, they don't take treatment as we prescribe. But we call it as poor drug compliance or adherence to treatment. People don't take it, even for ourselves. Like, how many of us really take antibiotics as prescribed for 5 days? If you have some infection, you take for first day, second day, third day you're feeling better, you don't remember to take it and you then stop it. So it's a very universal fact that patients, they don't take medicine as per your prescription. So when you're prescribing morphine 4 hourly, double the dose at bedtime and rescue dose, and then you're writing Bisacodil, and then you have so many other cancer medicine, do you think our patients are really taking it? Most of the time they don't take it. And when they come back and they say, I've got pain, you increase the dose without realizing that patient has actually not taken your original prescription as per as advised. So very important to check. I train my nurses all the time. Whenever the patient comes back, first thing, take out the medicine, ask them to show the medicines and ask them to explain whether they took the medicines properly or not. And you'll be I won't be surprised if they say no, because that's what the fact is. They don't take medicine as per prescription. When they say pain is not better, don't jump to the conclusion. So those who hopefully one day you'll come to India, and I think even your centers where they're practicing palliative care, they have this drug chart and they write medicine like this. They go that extra mile to take that extra effort to explain to the patient. They put it on timings. They even write in our drug chart, we have clocks also drawn like this. Those who can't read, they look at the clock and they make sense. Okay, 10 o'clock, 2 o'clock, extra dose, like that. And this is for pain, this is for constipation. If possible, we encourage to write in local language. We take that extra pain to explain the medicines to the patients. And our nurses will spend considerable time doing that in our team. So drug compliance is a big issue we have to ensure before you decide this patient pain is not better. These are different adjuvant medications which we normally use. Like I said, steroid for nerve compression pain we use, tricyclic antidepressants for and anticonvulsants for neuropathic pain. Ketamine sometimes we use for when we think it's central pain. It's not very common. It's never a first line. And muscle relaxants, smooth muscle as well as skeletal muscle relaxants. These are the adjuvant medicines we use. And remember the total pain, the concept of total pain. Pain is often not just physical, social, emotional, and spiritual. So if you focus on this part, sometimes you never achieve good pain relief if you don't address to these issues. This is what we call the concept of total pain. I stop here. Vinila, I think we'll do another session on neuropathic pain in some later part of that because it's too much of information otherwise.
Yes.
We are giving.
We are going to have
I'll just take
1 hour
questions.
of communication now. So we'll club that and this together again.
Yeah. So we'll discuss separately neuropathic pain. Why is my not screen sharing not stop?
Stop. You can see.
Stop?
Yeah.
I'll take questions, any open questions you have. What we try to discuss is, we looked at the common opioids available and we divided them into weak opioids and strong opioids. Weak opioids, step 2, for moderate
of action in increasing the doses of morphine. If it is the 10 mg fourth hourly today, for example, 10 mg fourth hourly for 24 hours is nothing but 60 mg per day. And still the patient is in need of morphine or the pain management. When you give an extra doses of morphine, it itself means that he's in need of it. So morphine has to be given much more. So if that is a 2 or 3 doses, assume that 3 doses of morphine was given in the meanwhile in this 24 hours. That means that he's already on 60 mg. And over that, apart from that, this patient was in need of 30 more mg of morphine. For tomorrow, when you assess the patient again, you come to know that he's on 60 mg, with which he also needed 30 more mg of morphine, which means 60 plus 30, 90 mg of morphine. So tomorrow the dose would be maybe 1.5 tablet of 10 mg morphine, which means that 15 mg fourth hourly. So this is how it should go in the way. So when you add some other NSAIDs or other drugs, maybe the patient's pain would be under control for a time being. He'll have the pain again and again. You can't continue this NSAIDs. You can't go up to the other drug again. Skipping up the medications is a very big problem, very big mess in our medicine. So we have to be very careful with that. Okay, thank you, Terry. Just wanted to add.
Yes,
This is a very basic process, protocol by which we manage pain. And remember the baseline psychosocial and spiritual support to make the holistic pain intervention. And by the clock, by the mouth, and by the ladder. Remember the ladder. Any thoughts? Subcutaneous morphine. Okay. If the patient is on oral morphine and you over a period, a patient has become unconscious now, he can't swallow, he's unconscious, or patient has got severe bad oral cancer and is just can't swallow, or esophageal cancer, is dysphagia, total dysphagia, he can't swallow, or unconscious, which we typically see in end of life care. Now he's on oral morphine, you can't stop oral morphine because he's in a lot of pain. So you have to switch over to parenteral morphine. That's the time we use subcutaneous morphine. So what we do is we convert oral morphine to subcutaneous, and it has a formula. We say 3:1 if it is intravenous. Suppose you want to start intravenous morphine, we say 3:1. If it is subcutaneous morphine, 2:1. Now, for example, patient is on 10 milligram 4 hourly. And I said in 24 hours, you have 6 doses. So in 24 hours, you have 60 milligram of morphine. Now this patient has become unconscious and I need to give him subcutaneous route of morphine. So what I'll do is, I said subcutaneous means 2:1, which means 60 divided by 2. So his 24-hour subcutaneous requirement is 30 milligram. And the 30 milligram, either I divide into 6 doses or I give it as a continuous infusion. Do you have infusion pumps in your hospitals? You can use infusion pump. So if you're using infusion pump, I'll set infusion 30 milligram of injection morphine in 24 hours or 12 hours, 15 milligram. If you don't have infusion pump, fine. You can still go for intermittent dosage. So 30 milligram, I'll divide to 6 doses. So it will come to around how many doses? 5, 6, 35 milligram. So 5 milligram every 4 hourly subcutaneously. And we'll discuss separately about subcutaneous route of administration, what is the site we use, what are the precautions. But generally, the conversion is 2:1 when you're thinking about subcutaneous route, 3:1 thinking about when you're converting from oral to intravenous. I think you must be very tired, end of the day, and so much of bombardment of information. So, okay, just take it easy. Read the book which you been given. It has It's a very basic book, especially Robert. Vanilla, what is the plan that Robert Pecker's book, Introducing Palliative Care?
And share the soft copy with the doctors now.
Sorry?
We have shared the soft copy of the book with Dr. Surenan. So we asked them to share, inform the candidates and then share it with the candidates. So I'll just check with Sir, shared or not, or else, and it should not be sent out to
We will share
anyone
that
else.
resource. Vanilla will be reminding us once again, Dr. Suren. So just start reading that basics. So just read the basics. Hello? Can you hear me?
Yes, ma'am, we can.
Read the basics. And then when you go to your clinics and see such patients, you will recollect whatever we discussed today. It's okay if you don't remember all this in today's end of the day. And we'll be sharing the slides in the PDF format. And you can have the slides also as a reference. I think all of you must be so tired, and this COVID stress must be beating you down. All of us the same year. So I won't take a lot of your time now. So thank you very much. If you have no more questions, we'll wind up for today. Over to you, Vanilla.
5 minutes will be breaking into the main room. So then you want me to share the poll questions?
No point now poll questions doing it. Because we'll already discussed. Maybe the first question we can share.
Sure.
Just to get an understanding. Can we go back to the main hall, our group?
Yeah, you can directly just say, I'll admit all of you to the main room. 1 second.
I'll leave the room.
Yes.
than the patient requires. பேஷண்ட்டுக்கு அவசியத்துக்கு மேல நம்ம மார்ஃபின் டோஸ் கொடுக்கும்போது ட்ரௌசினஸ் வரும். ஓகே, நெக்ஸ்ட் மார்ஃபின் இன்டியூஸ் பியூரைட்டிஸ். மார்ஃபின் சில நேரம் அரிப்பு உண்டு பண்ணலாம். பட் சம்டைம்ஸ் இந்த அரிப்பு நம்ம குளோர்ஃபினரமின் അല്ലെങ്കിൽ நம்மளோட ஆண்டான் செட்ரன் அது மாதிரி ட்ரக்ஸ் கொடுக்கும்போது இந்த அரிப்பு மாறும். சில பேஷண்ட்டுக்கு இந்த அரிப்பு மாறுறது கொஞ்சம் ரொம்ப கஷ்டமா இருக்கும். அந்த நேரத்தில் நம்ம வேற ஓபியாய்டு கொடுக்க வேண்டி வரும். But initially we can try with chlorpheniramine and ondansetron. இவ்வளோ நேரம் நம்ம பார்த்தது side effect. Side effects you can manage. Constipation, nausea, vomiting, drowsiness, pruritus, they are all side effects and you can manage. Next நம்ம பார்க்கிறது toxic effects.
Hello, Vanilla.
Yes, ma'am. Yes, moving to main session in 4 seconds. We're done.
The two couple of work for all of you. Please share your feedback because this will help us to do sessions better next time. The link to feedback will be shared with you. And also there's a quick polling, one poll, which all of you, I request all of you to do. Is that this feedback, Vanilla?
Yes, ma'am. That's feedback. And this.
Please click on the feedback and it won't take a lot of time. Just give your feedback. If you need any improvement, let us know. Otherwise, because we are trying our best to make it as useful for you because of the time you're giving to us so that you learn end of the day. It's going to take time, Vanilla, or we just otherwise?
Whole option, ma'am.
Yeah.
Yeah. Done.
I want the other poll, not this one. Vanilla, this we already discussed. I want the other
question, ma'am.
Question number 1.
Hello, ma'am. So actually, like in the first thing, like there are two these things. So we in each multiple choice option, we can only have 10 options. So we had to break the first question into 2 parts. So
we'll do it next time, Vanilla. Let's leave it.
Oh, shall I close this, ma'am?
Yeah.
Oh,
please. Yeah, sorry about that. Okay then.
Yeah.
Any housekeeping announcement?
Yeah. Thank you so much, Terry. I think have you completed? Sorry, a session, or do you have?
I had a very small part, non-pharmacological management, but I think they'll be able to follow it when they read the notes. If they want, I can discuss that whenever it is convenient.
We can fit in with some session. It won't take a lot of time. Maybe 15 minutes we'll give to Terry.
Yes.
Sometime later. That's very important. I feel non-pharmacological, we can't make it less important. So let's do it sometime.
Yeah. Maybe after a week or something like, can I schedule it, Terry?
Yeah, no hurry.
Yeah.
Point of
Sure. Thank you so much. And thank you once again. I know it's like very long day for all of you, giving your valuable time in attending the sessions in spite of your busy schedule. Thank you so much. So based on the convenience of the participants and the faculty have kindly agreed. And from here onwards, we are going to have your sessions not twice a week, but once a week, which will be on every Wednesday. And the sessions will be from 7 p.m. to 9 p.m. So there are no further sessions on Saturdays, and there are not going to be any sessions on Saturday evenings. And the sessions will be continued only on Wednesdays from 7 to 9 p.m. So we are going to speak to the faculty and schedule the sessions accordingly. And next session will be by again Ms. Stella and Mr. Swarup on wound management and lymphedema management. So again, it's a common session for all the doctors and the nurses. These 2 sessions are not going to be in the breakout rooms, and we'll be meeting on next Wednesday, 7 p.m., which is 29th May.
Thank you. Thank you, Vanilla.
And please submit your valuable feedback before you leave the meeting. Thank you so much. Thank you, Gayatri Madam, and thank you, Terry, for your time. Thanks a lot.
Thank you. Bye. Good night.
Good night. Please, candidates requesting all the participants to share the feedback without fail.